everybody. Welcome to the Q&A Cafe. Here we are in Georgetown at the Georgetown Club. And very happy to have everybody out on this end of summer day. I always like to put a timestamp on these interviews because they're so newsy. A little bit of news that I'll just say here for everyone is that this is actually the 20th anniversary of the Q&A Cafe. And it's very fitting in a way that our guest today is Dr. Scott Gottlieb to talk about COVID, because when the Q&A Cafe was started in October 2001, it was after the 9/11 terrorist attacks. And the whole idea was to bring the community together to answer questions, calm people down about what was happening. And it's a sad coincidence that here we are 20 years later, coming out of a crisis where now more than 700 million?
700,000.
700,000, I'm sorry. I don't know what the global number is.
2 million?
Okay, but welcome, Scott Gottlieb.
Thank you.
It's good to have you here with us. Yeah. A little bit of full disclosure too, because Scott and I have been working together for a while now, and a shout out to Shani Ben-Ezra, who's here in the audience, because in my other job, I'm a producer for Face the Nation, as is Shani. She's actually our COVID producer. And back at the very beginning of this, when we barely knew what we were trying to wrap our arms around, on a Friday night, somebody said, you ought to see if you can get Scott Gottlieb, he'd be great. And click, 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 I reached you, you said yes, and do you keep count? How many times have you been on Face the Nation now?
Probably close to 80.
I love it, I love it. And we'll all be sad when it's not every week, but it might also mean something good that we're...
It'll be good when it's not every week,
yeah,
for all of us.
Coming out of this. This has had such a dynamic impact on your life. Yes, you had a long career in public service. You were the head of the FDA. You have a perch on CNBC. And then this happens, and without actually, I would say, actively running for it, you have become a figurehead for a lot of people on COVID. What has the impact been on your life, professionally and personally, because of this crisis?
Look, I appreciate the question. I appreciate the opportunity to join Face Nation. I mean, that gave me the opportunity every week to share perspectives in terms of what I felt people needed to know to try to improve their lives, improve their safety. We spent a lot of time, I would spend a lot of time on weekends with Shini and others, trying to think about what I would say on Sundays, because I wanted it to be distinct and I wanted it to be more the kind of information that was practical, not just political observations, but practical, so people could think about, what the outlook looked like, what their future looked like, how to plan for what was unfolding. And that was hard to do because things were changing so quickly, and this whole ordeal has been so unpredictable. Look, the work on policy related to COVID, I've had to subordinate a lot of my other activities and a lot of my other work. A lot of my other public health work. I was doing a lot of work on tobacco and smoking cessation prior to this.
Vaping, right?
Vaping, exactly. And haven't been as focused on some of those issues. I've been fortunate that I've been able to, do a lot of the work from home. I haven't had to travel as much, and so I've been able to protect myself, protect my family. So I'm a lot more fortunate than many people in the setting of the pandemic who had to go out and work in jobs where they had to put themselves at risk. But it's been a difficult year for all of us, and this has been consuming, and certainly finishing the book took a lot of time.
Well, and let me just say, you managed in all of that to also write this book while we're here today, Uncontrolled Spread. How do you write a book about a pandemic while the pandemic's still happening?
I tried to go beyond just sort of the political narrative. I think a lot of the narrative is that we were made excessively vulnerable to COVID because of political failures. And there were certainly political failures in our response early on and all the way through. But I tried to look at the more systemic features of government that I think are structural, that left us weak and vulnerable to this pandemic. And what I did was focused on areas where there were things that went wrong, and then I tried to identify the solutions, what we could do differently. And in all candor, I thought that this book would come out at a point in time when this debate about how we prepare better for the next pandemic was happening in earnest. I'm actually a little surprised it's not. I had a vision of handing my book out in Capitol Hill as people were
walking around
debating,
maskless.
right, exactly, and debating what we were going to do to prepare better for the next pandemic. And that debate just hasn't started yet. Now, it could be because we're too in the throes of the current pandemic to really contemplate how to reform government to better prepare for the future. But there's not really even an active discussion about that right now, and that does worry me. And the other thing that worries me is that I think public health officials and public health institutions as a whole, I think that there's been a certain skepticism generated of public health advice. And this goes beyond just right and left. I think it certainly breaks down along ideological lines, but it goes beyond just right and left, that there is this sense among the public that the advice we got was always changing, it wasn't informed, it wasn't timely.
Yeah.
And any set of proposals on how to prepare better for the next pandemic, which I try to lay out in the book, is going to have to be predicated on empowering public health officials and public health institutions in a time of a crisis like this. And I think there's going to have to be a more fundamental debate convincing enough of the public that actually makes sense, that public health institutions should be rebuilt, reinvigorated. Public health officials should be empowered, because there's going to be a lot of folks on Capitol Hill. Again, there'll be ideological divides in this issue, but I think it will transcend that, who are going to say, you know what, maybe we should have more supervision of what public health agencies are doing. Maybe part of the problem is public health agencies didn't have enough oversight, and that's going to be a tough debate.
With your experience as an administrator, what if, I don't know how this appointment actually happens, but what if they came to you and asked you to run NIH, since that's going to be opening up since Francis Collins announced his?
Yeah, I wouldn't be in that. I mean,
do they promote from within, or do they bring somebody
in all
from
candor, I
outside?
think the NIH candidate, I don't have the right pedigree. Let me just say that.
I don't know.
The NIH director has always been someone who's come out of the research community, someone
So
who's
comes up through.
not necessarily up through NIH, but someone who's seen as a top researcher, someone who runs a top academic research institution and has administered large research budgets. Francis certainly came out of that mold. Most of the NIH directors have come out of that mold.
Would they ever promote Fauci into that job, or is that just not the right fit because he has this thing he does that's his thing?
Yeah, my understanding is Dr. Fauci's been considered for that and other roles in the past, and the struggle I think he has had is he hasn't wanted to give up NIAID at the same time, and so the question is, could he hold both? But I think he is.
I can already hear the Twitter.
wedded to his role at NIAID. That'd be hard for him to give that up.
Yeah.
So he'd have to do both.
Yeah. What would you say it is about your own personal story, education, experience, how you grew up, that prepared you for this, for not just this crisis, but even your role at FDA? What was your path? Who are you? Who are you, Scott?
Well, sir, I think the role at FDA was certainly transformative, and it wasn't just being commissioner, but working the real sort of transformative move in my modern professional life, if you will, was when I was hired back in 2002 to be a senior advisor to Dr. McClellan. He brought me on. I had just finished residency with the Samaritans here, and I was working at the American Enterprise Institute as a fellow, and Mark was coming in to be commissioner of the FDA at the time. This was in the Bush administration, and he was doing what people usually do when they're coming into those jobs. He was meeting with all the think tanks and all the groups in Washington, and I was the young person at FDA doing FDA policy, and proceeded to tell him everything that was wrong with the agency and how he had to fix it. And he called me up after that, shortly after, and said, hey, you want to come aboard to be a senior advisor to me? And I actually struggled with the decision, which in retrospect seems absurd, because it was a transformative opportunity in my life, but you don't know it at the time, how transformative it's going to be. And I took the job with Mark. I was a senior advisor to him, developed a close relationship with him professionally, and then went and worked for him at CMS when he went to go run Medicare, Medicaid. And then I was out of government for about a year and was recruited back to be deputy commissioner of the FDA in 2005, and I was there from 2005 to 2007. And I think what was really transformative was the opportunity to work with really good heads of that agency and learn from them. Especially Mark, Andy von Eschenbach. They had a very good ethic, a very strong public health ethic in terms of how they governed that agency, how they focused the agency's mission, and when I went back in as commissioner, I had all that learning. I mean, there's no substitute.
Yeah.
FDA is a very difficult place to operate. There's a very steep learning curve. But even more than that, understanding the culture of the organization, how to galvanize action, how to earn the trust of the professional staff and inspire the work, how to talk about what you're doing in the context of the public health mission of the agency, where there's a very discrete esprit de corps that sort of drives the agency.
Yeah.
I had that all going in.
Yeah, I was going to ask you who your mentors have been, but I guess you just told us, right? I mean, these various gentlemen along the way. But you were a practicing physician at the outset.
I practiced all through my government service. I never stopped, except when I became commissioner, I wasn't practicing anymore.
Yeah, but
I don't think it'd be good to be commissioner of the FDA.
Right. But where did you go to medical school?
Mount Sinai, New York.
And then where did you first practice?
Well, I did residency at Mount Sinai Hospital in New York, and then practiced as a hospitalist at Stanford Hospital.
Yeah, but somewhere along the way you realized that being an administrator or being in management, so to speak, was a...
No, I don't think I ever made the decision that I wanted to be, managing a big institution or running a government agency. I made the decision that I wanted to be engaged in public policy, and what allowed me to get involved in public policy was the ability to write about policy, to sort of put forward policy ideas, get them published in prominent publications. I mean, I was a resident or a medical student, Samara will remember this, writing for the Wall Street Journal editorial page and the New York Times editorial page and USA Today. So I was able to get my ideas out in a sort of fashion that they were getting noticed, and that's why I had the opportunity to join the American Enterprise Institute, which was a big break at my age. I mean,
You've been with them a long time.
I've been with them a long time, but I was the youngest fellow ever hired into that organization, and then that put me on the radar of someone like a Mark McClellan. So if you ask me what sort of the enabling technology, if you will, it was the ability to write about policy and get my writing published prominently, but also write from a consistent point of view. I mean, I was consistently pro-market, libertarian, and I think in Washington, there's a higher currency put on people who can express a clear point of view consistently. People, when you're early on in your career, people are worried about making strong political arguments one way or the other. I mean, people on social media don't seem worried about it anymore, but people who want to do something professionally, I think the currency in Washington, in my view, is having a clear, well thought out point of view that is expressed from either the right or the left. Because a lot of times you'll look at an issue and you want to know, what are people who have are more progressive, what are they going to think about this, and what are people who are more pro-market going to think about this? And you want to find someone who articulates a very clear viewpoint from a particular persuasion. It doesn't break down that cleanly, obviously. Issues are complex, but I think having that consistent point of view is very important.
And increasingly risky.
Depending on how you pitch it.
Well, but I mean, it's not as present as it once was. There's a lot of shifting sands just for survival. But let's talk about COVID. One of the guiding principles of journalism is the words who, what, where, when, why, and how. So why don't we approach it that way? We don't know who yet, do we? You have theories on where COVID came from.
Well, we all have theories on where COVID came from. It came
but
from
we
one
care
of two
about your theory.
Yeah, well, look, it came from one of two places. Either it came from nature, from a so-called zoonotic source, from an animal or some intermediate species that jumped from bat to another animal, maybe a pangolin, to humans, or it was brought out of nature into a laboratory where it might have undergone some modification, not intentional modification. I don't think that this is the result of deliberate genetic alteration, but modification to allow it to be easier to experiment with, and in the process of modifying it, make it more humanized.
Yeah.
And ultimately there was an accident, people got infected, and then that was the first super spreading event. There's plenty of precedent for what I just described. Now, there's not a lot of precedent with those kinds of lab accidents sparked global pandemics, but when you have a dangerous contagious pathogen escaping from a lab, the opportunity always is there. I think if you look at the history of this, what I would say and what I've said on the show is the side of the ledger that points towards the zoonotic source has at best been stagnant, and I would argue has diminished over time. And the side of the ledger that points towards a lab accident has expanded over time. So why? One, we've looked exhaustively for the zoonotic source and we haven't found it. Now that doesn't prove it doesn't exist, but certainly if you've looked at 18,000 animals, you've culled 18,000 animals or more, and you haven't found it, you're running out of places to look. Again, doesn't mean there's not a reservoir somewhere that we're not seeing. Second, the so-called wet market, the market in Wuhan that was first perceived to be the initial source of the outbreak on a premise that there was some animal brought into that market, slaughtered, you had a bloody spray, the initial group of people got infected. It's now firmly proven that that was not the case. That market was a stop along the way for the virus. It might have been the site of an early super spreading event, but it was not the source of the virus. The Chinese government, the Chinese CDC have fully conceded that. So the other side of the ledger on the lab with the WIV in particular, but there's other labs in Wuhan that were doing work with coronaviruses. We know they have coronaviruses that have never been revealed publicly, novel coronaviruses. We know there was an outbreak of a novel coronavirus in 2019 in pangolins that had features that look a lot like SARS-CoV-2.
Don't lose that thought, but don't we keep viruses in the basement of NIH too? Because I've been there. I've been in the lab where they have these giant tanks with the deadly. I'm not saying they have COVID there, but this is not unusual.
No, it's not. No, there's nothing unusual about it. But the WIV had the world's largest repository of novel coronaviruses. They didn't make the sequences public. We still don't know what's in their inventory. We know that there was a novel virus discovered in proximity to SARS-CoV-2 that had features that looked like SARS-CoV-2. This was published, but they never published the whole sequence. We still don't have those samples. We know they were doing experiments with transgenic animals, meaning that they had animals with fully human immune systems that they were infecting with coronaviruses. We know they were doing this work in BSL-2 labs, which is not the appropriate level of security to be conducting research with a dangerous respiratory pathogen. We know that there were lab workers that became ill right around the time that SARS-CoV-2 was believed to make the first entry into humans. We know that they had bad lab practices. There had been repeated documentation of poor practices in that facility, including an article in the journal Science when it opened, raising questions about the integrity of the facility and the training of the people who work there. And we also know that the Chinese government have not been forthcoming with certain key information. They still haven't released the source strains. Why not release the original strains? They haven't released data on the lab personnel in that facility, whether or not they had SARS-CoV-2 or not, their antibody test results. They haven't released an inventory of what's in that facility. We don't have access to that pangolin coronavirus that surfaced in March of 2019. And I'm not saying that that's the virus, but all of these things are pieces of evidence that if you had them, you could disprove certain theories.
But your theory is we need a whistleblower.
My theory is that this is going to be a battle of competing narratives unless you, number one, either on the one hand find the intermediate source and prove it came out of a bat cave or nature, or you have some piece of evidence that we've either obtained or a person that we've gotten access to that can definitively prove that it came out of the lab. My hunch is that the circle of people, if this did come out of a lab, and the final point was the behavior of the government of China certainly has to be a factor here too. It's fair to draw inferences from their behavior, but short of someone who knows, who tells us, or something intercepted, we're probably never going to be able to prove that. And I think it's likely the case that if this did come out of the lab, the circle of people who know that might be exceedingly small.
Are we beyond this being that relevant, though?
No, we're not, because the reason why this is relevant from a policy standpoint is because if you assess that there's a high probability that this came out of a lab, or even a moderate degree of probability, it changes what you do to get in place better global governance to prevent the next pandemic. We're going to go to the World Health Organization, the World Health Assembly, and we're going to focus on zoonotic risks, and let's sample more animals, and let's do capacity building in countries where these viruses first emerge, and let's sign some more binding international agreements that we're all going to share information when we have the next outbreak, none of which is going to work because we've done this before and it hasn't worked and it didn't work this time. But if you assess that this came out of a lab, suddenly you have to get in place better international regulation around what research can be conducted in what kind of lab. Any research with a novel respiratory pathogen should not be conducted in a BSL-2 lab. We should get better governance around BSL-4 labs like an International Atomic Energy Agency type structure to govern them. We should have a global agreement that we're not going to publish sequences on novel respiratory pathogens that some someone in a semi-sophisticated lab can't take that sequence out of the literature and manufacture a dangerous pathogen. There's a whole host of things that you're going to do differently around the global governance. And we're going to also put better governance around where these BSL-4 labs are and who has them. Because what ends up happening in the world is the riskiest experiments go to the countries with the poorest controls. Because if you bring an experiment that you want to do gain-of-function research with measles to make it more like the flu, there's no U.S. lab that's going to run that experiment. But there's probably some other BSL-4 labs that might be willing to do that. So the riskiest research ends up going to the labs with the poorest controls in some cases. So if you have better governance in place, you can prevent those kinds of things from happening.
Without going into a lot of detail, because you might have to kill me, I know you consult with the intelligence community in the federal government. Do you feel that they're listening to you and making a renewed effort to be more involved?
Without going into too much detail. I think that and I talk a lot about this in the book, I think we're going to have to get our national security assets much more engaged in the global public health mission. And that's not to say that they weren't previously. But historically, global surveillance has been something that's been seen as the domain of the CDC and public health officials. And they didn't want our intelligence agencies anywhere near the mission because their perception was
turf wars.
Not just turf wars. Their perception was that if the CIA was engaged in doing overseas surveillance for these kinds of global public health risks, then anyone coming from the NIH would be perceived to be a spy. I think I don't think we can afford that kind of logic anymore. And quite frankly, I think any American official traveling over abroad is always presumed to be a spy anyway by every other country. So I'm not sure that there's some, something that's going to be breached here that suddenly the relationship's going to be different. Every other country is doing this kind of surveillance. We're going to have to do it as well. There were things that were knowable in mid-December that could have tipped us off that there was a novel SARS-like coronavirus spreading in Wuhan, person to person through asymptomatic transmission. That was a knowable fact probably by mid-December with good surveillance. We didn't know that set of facts I just described, we didn't really know that till mid-January. So we could have had maybe a month head start on understanding some key attributes of this virus. And in the hands of good political leadership, a month is a long time to start preparations. So I don't think we can afford the luxury of not having our tools of national security engaged. And the final point on this is, if anything, we're going to go to the World Health Assembly and we're going to all hold hands and we're going to say we really mean it this time. Next time we're going to share information. But if anything, the global response to COVID taught nations not to be forthcoming. Because what's the first thing that happened when the British said that they have B117 spreading? The French closed the channel. I mean, we all remember the pictures of the trucks lined up outside the channel. Everyone tried to isolate the UK, including the United States. So every country looking in on that now says, if I raise my hand and announce that I have a deadly pathogen spreading, I'm going to be isolated. So I'm going to try to quietly get control of it. So I don't think that we can trust countries to be forthcoming. We're going to have to be doing better surveillance, have sources on the ground, and some of this information is electronic and can be intercepted as well.
Have you been engaged with China yourself very much? I mean, have you been to the Wuhan lab? Have you?
No, I mean, I visited China. I don't think I could visit there anymore. But I mean, I could visit. I just can't
You're
come home.
You're a spy.
So, I had engaged a little bit with my counterparts when I was at FDA. So my engagement was mostly with counterparts from their FDA. But and a lot of it was around what we traditionally try to do, capacity building, and a lot of the stuff in the media about NIH did this with the Wuhan lab and the Galveston.
Yeah, it's a lot of misinformation.
It's a lot of misinformation because people lose sight that a lot of those relationships are sought after because we want to have some connection to facilities where we have concerns.
And this is normal and traditional.
It's the normal course of how we do things. This is part of the multilateral engagement. If you have concerns about the Wuhan Institute of Virology, you're going to try to find an American academic collaborator, so you now have some insight into what's going on in that facility, and hopefully some collaborative work going on, so you have better awareness. That's the way you gain that.
You're aware of the narrative about Robert Redfield when he was running CDC, dealing with his counterpart in Wuhan, I think, or just in the government.
In Beijing, yeah.
In Beijing. And the degree to which Redfield was distraught because he was seeing what was happening and not feeling that the response was commensurate with it. And And in at least a few different accounts of this occasion, it drove him to tears because he was so worried.
Yeah, it does appear to be the case that the CDC, the Chinese CDC, was kept in the dark. I mean, there was the suppression of information inside China appears to have happened at multiple levels. And I talk about this in the book. I mean, there was clear suppression at the provincial level from the officials in Beijing. And then once the officials in Beijing were aware of what was going on, which was late, which probably was until the end of December in China, then obviously there was further suppression of information from the global community. But there wasn't good information flow from China as well. I think that there was a lot of suppression at a local level. And the Chinese CDC seems to have been in the dark based on everything that we can glean until sort of late December. And that's when the discussion started with Redfield and with the US CDC as well. Now, then what was the Chinese CDC's behavior subsequent to that once they had all that information? Did they act appropriately? I think that's a separate discussion.
That you probably don't want to have right now. It's okay, it's okay. Do you remember what you were doing, where you were when you first started to get the threads of this happening? I mean, do you remember what you first told your wife?
Well, I remember the first time I grew very alarmed by it. It was Martin Luther King Day weekend. I recount this in the book, and it was also recounted by Yasmina in the book Nightmare Scenario.
It's a good book too.
She got a hold of my messages, but good sourcing. It was the day that the number of cases in Wuhan, the reported cases, had gone from 50 to about 200. I think it was like 194, and it was all reported that all 194 people were in the hospital, severely ill with pneumonia, with this novel virus. And that's when I grew alarmed. Number one, because of the velocity of the increase in cases, but number two, the fact that all 200 people were hospitalized with severe pneumonia. It's very rare that a respiratory pathogen just presents a severe pneumonia, especially one that is this contagious. And so it was a tip-off that there must be probably thousands of cases, hundreds, if not thousands of cases that aren't being measured. They're just seeing the ones presenting for intensive care in China or reporting those. And so that was when I called the White House for the first time. I called Joe Grogan, the head of Domestic Policy Council, who had worked with me at FDA back in 2005 when I was there as a deputy commissioner. And I said, you should call the department and make sure they're coordinating a response, because you're going to need CDC working alongside FDA and maybe BARDA to try to scale up. And I talked about diagnostic tests with him. We're going to need to get testing in place. And that's going to require an excessive level of coordination across the department that doesn't normally exist. So he texted the department that day to schedule a briefing for that Monday. It was the first time the Domestic Policy Council had gotten engaged. And the Domestic Policy Council is sort of a political component of the White House that's closer to the president. The National Security Council had already been monitoring this at a lower level, but this was the first time that a very senior level political component of the White House.
Closer ring.
Yeah, exactly, close to the president. And so that day, it was separately reported that by the Washington Post that the secretary called the president for the first time, President Trump for the first time, to brief him on COVID, and pulled the president off the golf course and briefed him on. This is the reporting of the Washington Post. And what the Washington Post reported was that the secretary got a very tepid response from the president, who proceeded to berate him over the policy on vaping that had just been put forward. And it was interpreted by the press and the article as a sort of an indication. It has been interpreted to this day as an indication of the president's sort of indifference. I had a little bit of a different reading on that. I think it was, it might have felt haphazard. Why am I being briefed? Why am I being pulled off the golf course to be briefed on this now? What's the urgency? And it felt a little rushed. That's my perception of what happened. I don't know that the.
Well, you're being put on the spot.
Well,
in a way,
it was odd to pull the president off a golf course and brief him on something that's sort of speculative and kind of you don't have a lot of information. And I don't know that the involvement that morning of the Domestic Policy Council is what instigated the department to then phone the president. I have my own theories on what happened, but that's the sequence of events that day, and that was the first time that I had contact with the White House about this. And then I continued to have contact with them. That was the first time I became really alarmed. I mean, to answer your first question, that's when I became really alarmed that morning. And I don't remember my first words to my family about it, but
you probably called your parents.
I don't think I hit the red button and told everyone to start stockpiling food and move into their basement at that point. But the second time,
Makes for a dramatic moment.
I got very alarmed towards February.
Yeah.
There was an op-ed I published in sometime in sort of mid-February with Lou Borio, who had been chief scientist at the FDA. I had detailed her to work on the National Security Council in the White House, where she headed up the desk that dealt with bioterrorism. And the op-ed basically said, the title was something like "Act Now to Prevent a U.S. Pandemic or U.S. Epidemic." And the lead of the op-ed said, we could be missing hundreds, if not thousands, of cases. Like, community transmission could be underway, and I was convinced community transmission was underway. That article came out, and the next day I was on TV, and I was listening to public health officials in the U.S. sort of saying, there's no community transmission. So far we've kept the virus out. And I called the White House again after that. After I got off TV, there were some hits before me where some U.S. officials were sort of saying everything's okay for now, and just said, how could you guys be so sure? Because if there's community transmission underway and people are showing up with COVID in hospitals, shouldn't we be telling doctors to use respiratory precautions? Shouldn't we be starting to change our practices? People could be testing negative for flu and have coronavirus instead, and we're not taking proper respiratory precautions because what doctors are hearing and nurses is there's no community transmission underway. And
anecdotal stories started popping up everywhere.
Yeah, and some of those were true. And so the response to me was, and this was a political official, was, we're pushing the CDC, and they're adamant that there's no community transmission because they were looking at the influenza-like illness surveillance system, and they weren't seeing anything unusual. And the ILI is basically data that shows how many people present with flu-like symptoms each week in the wintertime and test negative for flu. Because if they present with flu-like symptoms and test negative for flu, presumably they have something else. But on any given week, in the ILI, about 50,000 people present with flu-like symptoms and test negative for flu. So you could be having a burgeoning epidemic hiding in plain sight. And furthermore, if you look at the data, and we were looking at it at the time, Caitlin Rivers was one of the people publishing on this at the time, and I talk about her a lot in the book. The data was not green. It wasn't red, but it was flashing orange all month. It was at the high end of the normal range for the past 10 years. Certainly in the context of what was happening in Wuhan, that should have been concerning.
You tell an alarming story in the book about March 13th, and you are going to the White House because the president is going to announce a national state of emergency over the pandemic. And you arrive at the White House, and what do you find?
Well, people were still cavalier at the White House. The vice president shook my hand. I Purelled afterwards.
There were no temperature checks?
No temperature checks, no testing, no masks. People were crammed in offices. Look, it wasn't just the White House. I had been on Capitol Hill the day before briefing both the Democrats and Republicans, and there was a level of complacency at that point, too. I don't think anybody had an awareness that community transmission was underway already. People thought it was coming, but they didn't think it was underway, and it was well underway, and that's why we became so heavily seated. That's why what happened in New York happened in New York. I remember being on a plane. I was going out to, I think, San Francisco. It was the end of February, and it was someone texted me to tell me for the first time that there was a project underway, and I talk about it in a book, in Seattle, where some researchers had fashioned a coronavirus test, and they had a community-based project underway where they were collecting samples from people who thought they had the flu, who would self-swab at home and send in the test to see if they had the flu. And it was a way to see if you can do community-based testing for influenza. It just happened to be going on. It was like, just sort of fortuitous that it was going on. And the researchers realized, wow, we're sitting on all these swabs from patients who thought they had the flu. Let's see if any of them had coronavirus. So they went back and tested them. The government shut them down, by the way. They went back and tested them, and this was late February. And 1% of the swabs were hitting on coronavirus. So this was a point in time when everyone was being told there's no community transmission underway, and 1% of the swabs coming out of this were hitting on coronavirus. So that's a pretty good indication community transmission was probably underway.
Was there a point when you stopped going to the White House because you just felt, well, we shut down, or did you still get called there even?
Yeah, so my last trip to inside the White House may have been that March meeting. I was there a couple of times. Last one I remember was the day that the president got tested for coronavirus, and so that was after the trip to Mar-a-Lago where he was in touch with the Brazilian officials. I forget what date that was.
Bolsonaro.
But I had subsequent conversations with them. There was a point in time when they stopped calling me because I don't think they liked what I was saying. But
going on TV, giving your opinions.
But I had continued conversations with officials there.
There was also a moment that you write about. I mean, there's so many incredible moments, but that struck me, where Han is giving a speech to a convention of. Tell me what they are.
ACLA. So it was the American Clinical Lab Association.
Was it Atlas?
ACLA.
Oh no, it was Han, but
ACLA.
Okay. So what are they? They're lab technicians.
So this was probably the last meeting that these folks went to in person. This was a meeting of the American Clinical Lab Association. Basically, it was all the diagnostic manufacturers in the country. And what was
Quest
the date of it?
and LabCorp kind of things.
March 4th. So
yeah.
Researcher on a book.
Love it. Yeah, no.
Encyclopedia on COVID.
But okay, so it's still the same stretch of time.
Exactly. This was all pivotal time. These were the critical days.
You were alarmed every day and probably not sleeping at night.
Well, this day in particular. So
yes,
this was a moment. You had all the lab manufacturers assembled in Washington. This was the moment to go before them and say, you guys have to get in the game. I mean, it's already too late, right?
Yeah.
This should have happened in January, but now you got them all together. And the FDA commissioner went and gave a speech that was boilerplate, no call to action.
20 minutes.
Just a recitation of what was on the FDA website. I called the White House, and Debbie Birx and Debbie Birx organized a meeting at the last minute with them and the vice president. But quite frankly, that was the wrong nexus for this to happen. I mean, because you need the subject matter experts in the room. The commissioner wasn't there, the secretary wasn't there. You need people who come from the public health institutions to be able to direct these companies on what to do. The White House can give a nudge, but you didn't have the leadership below the level of the White House to drive these companies into the market and make the assurances that they needed. And up until this point, they were having trouble getting what they needed from the CDC. They couldn't get the viral samples, they couldn't get they couldn't copy the CDC's test design because the CDC wouldn't share it with them. So it was a missed opportunity.
Because you were dismayed. I think it was a 20-minute speech, and what he did 3 minutes.
I tweeted out. I mean, it sounds so small talking about tweets I sent at moments in history.
Back in that era, tweets were.
What can you do?
Yeah.
So I tweeted out a long thread that said the end of it was that the industry is going to be judged by what they do right now.
Yeah.
And I got a call from the head of the association about 30 minutes later, who assured me that they were going to be meeting and getting together and trying to galvanize some collective action. But it was too late, and you needed to have the agencies involved. It was always too late.
I mean, that's why why COVID crushed us, because it was always too late. We were always, but with the time we have left, I thought that we should talk about questions, because Shani can attest to this. I can attest. And they're also well-meaning friends who call up and say, Can you ask Dr. Gottlieb this for me? Can you ask Dr. Gottlieb? But what do people ask you on the street? I mean, is there a trend in the questions that you get asked? Has something really thrown you for a loop? Have you received calls from, like, I don't know, a major celebrity like Beyonce calling you up and saying, what should I do with Blue Ivy about this? I mean, what? Talk a little bit about this experience for you.
Most of the questions I get, either online or just in person, are mostly people contemplating their own individual risk and what to do with their families. And you hear it's been helpful, because you get people contemplating scenarios that you might not have thought about in terms of a level of risk or some kind of setting of risk, and how policy might be or might not be affecting it. So a lot of questions are around, what do I do in this circumstance? And some of them are so... Can I travel? Can I fly?
Yeah, or should I take the train?
I have a child with this kind of need, and another child in this situated in this setting. How do I reduce the risk between children? Things like that, where it's very specific, and there's no clear answer. There's no clear guidance. And I think this is where we sort of failed as public health institutions. The guidance is so... it's so unclear. It's hard to decouple. A lot of what comes out of CDC. I mean, I've been critical of the guidance coming out of CDC, that it's hard for anyone to translate it into what does it mean for me practically, let alone a consumer. I mean, it's hard for even public health officials or physicians to look at the guidance and translate it into practical advice to people. And then, so how's a consumer going to decouple it?
What would you tell people right now? I mean, it happened just today. Friends from New York, where they're very rigid. You know, you have to show your vaccine card to get into restaurants. And then they come to Washington and it's a relaxed setting. How do you calm people in those situations? Or do you just tell them you've got to do your own thing, you know?
Yeah, look, what I tell people now is you've got to judge your own individual risk relative to the setting that you're in. I mean, some settings are higher risk than others. Confined spaces with poor air circulation, higher risk. Being in a high prevalence environment, higher risk. Being with a crowd that isn't, vaccinated, higher risk. And then what's your risk at home? If you're a vaccinated individual living alone or with other vaccinated individuals, the risk is lower than if you have young kids at home or an old relative.
Yeah. But that's going to change soon for the children, don't you think?
It will change for the children. It will change for children 5 to 11. And I think that's the two big inflection points psychologically, I think, for Americans in terms of getting beyond the sense of pervasive fear and risk is going to be being able to vaccinate our children. Because for people who are worried about this, part of their fear is bringing the virus back into their homes. And having an orally available drug that can treat the virus if you do happen to have a breakthrough infection or you're not vaccinated, have an infection, where there's a sense that there's something that could rescue you. I think we're just a couple months away from both. And so I think on the back end of that technological inflection point, psychology around this is going to change dramatically.
I think you've even said publicly, plan to spend the holidays with your family if you want to.
Well, I don't see why not. I think, again, this is something you need to judge your individual circumstance. So if I have unvaccinated young kids and I'm going to be with my parents in a confined space, even though my parents are vaccinated, sorry, Mom, they're old.
Yeah, but your father's still practicing medicine, isn't he?
Still,
yeah.
Yep, 80,
So
82,
props to
83.
him.
I would test my kids. I mean, my poor kids get swabbed so much. They sneeze and they yell at me like, it's just one sneeze. But I would test my kids.
I bet you get asked a lot, should I take Moderna, should I take Pfizer? Now, you're on the board of Pfizer. I'm saying it for you so you don't have to, because I've been told that you're saying you're on the board of Pfizer in media is a drinking game. So, you're blushing, I love it. Well, you are all about full disclosure. So but even with you being on the board of Pfizer, I don't think this is giving anything away. You weighed a moment of whether you would do one or the other. I mean,
well,
you think they're both fine, is what I'm saying.
I think that these vaccines are interchangeable clinically. And I think any data, I've said this consistently, because there's been studies that say Pfizer's slightly better, and there's studies that say Moderna, and every time I said they're pretty comparable.
Isn't that like changing lanes on the New Jersey Turnpike? This lane's going faster, I'm going to get over here. It's the lane to be in. And then all of a sudden you realize the lane you were in was the...
They're being studied differently.
Yeah.
You have different kinds of information being collected. Pfizer has a data set in Israel, so things are being revealed out of that data set. I think that these are clinically interchangeable vaccines. I think the J&J vaccine is an outstanding vaccine. If you look at the long-term data on that, people have gotten a very durable response. The 2-dose data looks exceptional. So I think that vaccine is also going to be a prominent part of our overall armamentarium here. But the two vaccines, I think, are largely comparable and interchangeable. And frankly, after a booster, any perceived difference is going to come out in the wash, because the level of immunity you're going to derive from the booster is going to exceed any small differences.
It also seems to me generally now people are able to get the booster. It's not too rigid.
That's right.
I know a lot of people of different age groups.
Well, they've left it intentionally flexible. I've talked to the pharmacies, and the advice that they've been getting from the administration is don't make it too complicated for people to be able to self-select for the booster.
Right. The other question I'm sure you get asked a lot, and I think I know your answer, but when's it going to end?
Well, look, I think that I've said many times, you've heard me say this, I think this Delta wave is the last major wave of infection. On the back end of this, prevalence will decline. We'll still be dealing with this in perpetuity. It's going to become an endemic virus, but not at these kinds of levels. And I think that we're going to be able to relax a lot of the public health precautions, because first of all, we'll have better tools, more of the population will be vaccinated. 90% of the population will have some form of immunity, either from infection or through vaccination on the back end of this. And so it's going to represent a different level of risk. We're not going to see the extreme hospitalization and death, hopefully. But that said, you talk to someone like Trevor Bedford, who sort of agrees with this, but his assessment is that you'll have evolution in this virus, and we'll probably have 80,000 deaths a winter from this. Now, that's a lot of deaths. That's a bad flu. So the 2017-2018 flu season killed about 80,000 people. It was a very bad seasonal flu season. But the problem is if we have COVID circulating alongside flu, and flu's killing 50,000 people every winter, and COVID's killing 80,000 people every winter, I don't think we can sustain that level of death and disease without changing fundamentally certain things of how we behave to reduce the risk of respiratory pathogens in the wintertime.
You say we're due for a bad flu season.
We are.
Will it be one that kills 70 or 80,000 people?
It probably will. I mean, what's going to happen is we're going to have a flu season. We haven't put flu immunity in the population in 1 year, maybe 2. We don't know how this flu season may be another year that's not a particularly bad flu season. So you're going to have flu come back 1 year, seasonal flu, that's going to have spread very widely because you won't have as much immunity. And the risk is you could have a mismatch between the vaccine and the prevalent strain of flu, because part of determining what goes in the vaccine is looking at what flu is spreading around the world. Well, if you've changed the contours of what's spreading around the world, we look to Australia. Well, Australia has no flu. They've sealed the island, or South America. So where do you look to find out what strains are going to become prevalent in the U.S.? So we may get that wrong because the methodologies we use don't apply to the circumstance we're in. Yeah. So if there's a mismatch between the vaccine and the flu, on top of lack of flu immunity, it could be very bad.
Well, our time is up, which leads me to say we could have talked for another 5 hours to cover everything in the book. So get the book. I think I told Scott after I first read it that it was a medical academic book that had a James Bond vibe. And I mean that sincerely. It's immensely readable. It's so useful. Everybody should read it. And you are just a darling to come do this.
Thank you.
Because I know how busy you are. Thank you. Thank you, everyone.